Thank you, Trish, and may I also commend you for all showing up for the 3:30 session. It's admirable. Again, I'm the executive director of an organization called the Massachusetts Housing and Shelter Alliance, which is an advocacy policy organization with a little bit of a difference. We're also an incubator of sorts. We actually act as an operational intermediary between the public agencies and our member agencies in terms of funding. Of the various programs that we may describe today, Mahasa itself isn't there doing any of it. It's one of our member agencies. We have over 90 agencies statewide representing 250 different programs: housing, transitional, permanent supportive, shelters, day programs, all serving unaccompanied adult homeless. The thing that's great about being back for me in New York City is that my first encounter with homelessness actually happened about 12 blocks from here on 135 West 31st Street. I'm actually a former Franciscan, and in the 80s, I was shortly assigned while I was going to graduate school to St. Francis on 31st Street. And while I was there, I was asked to take over for a short period of time for one of the friars who was going on a short sabbatical of a women's shelter of about 16 beds in the basement of what they called the Third Order Hall on 31st Street. And I can remember my impression at the time was what a poor response to the set of needs of the people that we saw in that particular program. And so I've come to this work with this sense that we could be doing something much better than emergency shelter for the people that we're trying to serve. When I took over the Massachusetts Housing and Shelter Alliance, prior to that, for about 15, 16 years, I had run, go figure, different sheltering agencies within the greater Boston area for that past 16 years. But all the time focused, again, on trying to create some type of housing that specifically provided an alternative to emergency shelter. And so although, you know, Home and Healthy for Good has gotten a lot of hype and people talking about it, even Dr. Gaeta was from Healthcare for the Homeless was even on CBS Evening News about that. The real reality of what has been happening in Massachusetts is trying to figure out some way of integrating the reality of healthcare into housing so that housing itself is recognized as a medical intervention specifically for the chronic homeless persons that we serve. And so the breakdown of it is, I'm just going to give a little bit of the story of the advocacy and the effort that led to that, and then I think Jim is going to really focus more on some of the real hard details in terms of the implications of that and what it means, particularly to ensure the tendencies of this particular population in housing. Interestingly enough, we have always put forward a particular view of housing. We have had lots of permanent supportive housing in Massachusetts, but we never had what you might refer to here, and we take your lead, quite honestly, from all that's been accomplished in New York, is around the development of low threshold housing. Most of the permanent supportive housing that we had in Massachusetts tended to be so-called compliance-based housing, and that it focused a great deal, obviously, around people being able to maintain certain requirements or compliance either with certain clinical or psychological conditions that are being set, or they had to be clean and sober in order to be able to secure or sustain that housing. We saw some of the great models that, quite honestly, we looked first here to New York and things that were happening, and we recognized that that had never been tested. But one of the things that we had been trying for a very long time to do was, and this came before Home and Healthy for Good, was figure out a way to link Medicaid resources to those services that we knew resulted in positive tendencies. again, anybody who's worked out there knows if you talk to a chronic homeless person or you're trying to house somebody, that they will tell you in moments of candor that it's not the psychiatrist that keeps them in there, it's not the ACT team that necessarily keeps them in there, it's not the psychiatric nursing that keeps them there. As important as all of those things are to have in any type of housing setup, what really keeps that person there is the person that shows up and knocks on the door every day and says, "What can I do for you today?" But ironically enough, at least in Massachusetts, nobody was funding that. And so, again, Mahasa, since its creation in the 80s, has always focused around the conversion of resources from emergency resources to permanent resources that work. And the first thing was community support program for people experiencing chronic homelessness. This was a Medicaid provision of that type of service that I was speaking about, where they would actually fund primarily undergraduate workers to those agencies who were willing to, again, do a low threshold housing model. Then how we got to this point is the interesting part of the story, is that Massachusetts behavioral health has a carve-out. It's managed care, and it's run by a private for-profit organization, the Massachusetts Behavioral Health Partnership. It's a subsidiary of Value Options. But in the contract that they had with the state of Massachusetts, they had a performance incentive. And each year, the Executive Office of Health and Human Services and Medicaid would issue a statement asking providers and agencies to submit proposals for these performance incentives. As a private entity, they made much of their profit based on fulfilling these so-called performance incentives. We wrote one, and surprisingly enough, after about 4 years of advocacy anyway, they agreed, and what the incentive called for was to come up with a model for reimbursing the type of service that I had mentioned before through Medicaid. And so, a little piece of trivia, I always have to share this. I know this is a little bit of a sideline, but the person, because I believe in giving credit to everyone who's involved, the person who actually wrote the incentive proposal was Dr. David Foster. And his last job, most recently, he lost just a few weeks ago, because his most recent job was he's the executive producer of the show House. So I love to just like throw that out there. He's a very amazing person in what he's accomplished in his life. But he was the guy who had kind of helped us in putting that together, was working for Mahasa at the time. So it's based on an 1115 waiver. What they did was they took community support program out of Medicaid and adjusted it so that providers could get a monthly rate, and great things started to happen. We were able to, working through licensed agencies like Healthcare for the Homeless, and again, much of this effort was based on the work that Jim had been doing for years in terms of cataloging the health issues specifically that this population faces. But we were able then to go out and link them together with homeless housing providers to put forward this first unique program that was reimbursing agencies to provide that level of service. As you'll note up there, it says that to date they've served 372 tenants, and it's estimated that it's resulted in about $3 million in savings if you count specifically medical costs. Again, in terms of creating this, I recently was at an event in the state of Rhode Island talking about various Medicaid things, and somebody made the great observation: if you've seen one state Medicaid plan, you've seen one Medicaid plan. And obviously, the complexity of trying to shape this to serve the population we serve is great. And so, in this case, for us, the behavioral health partnership and that carve-out served us well. It was very effective. During that, after that CSPEC came online, I started an effort with the legislature trying to get an additional money added that would match and go in with CSPEC to be able to do cost benefit and also to give a little more resources to providers willing to risk and try this. And interestingly enough, we secured the money, but what happened was one of the commissioners, who shall go unnamed, it was not earmarked in the state budget, and they utilized it for a different purpose. So the next year, I wasn't going to let that happen. So what we did was we created Home and Healthy for Good in the legislature as a legislative initiative that was focused again on the provision of low threshold housing. Now with Mahasa and a lot of the things that we do, this started in September of '06, again in a year after CSPEC had actually started. But the focus in relation to this was not that we were going to fund anything in its entirety. Obviously, what you're going to do is $600,000. But what we started to do was use it and utilize it to leverage other resources. I often refer to it as my stone soup theory of social change, is that you hand out a little bit of resource and say, will this change your mind in terms of what you're doing? And one of the great things, particularly in terms of the State House and the budget, was flexible funding. So you could use it either for your operational costs or you could use it for services. And we had always intended this as a pilot because what we were really trying to do was test out the cost-benefit stuff that we were seeing around the country to see if this would impact healthcare utilization in ways with this particular population. And we started out with about 12 agencies, and we're still with those same 12 agencies. And again, the most unfortunate thing about all of these efforts that we're describing to you is that we have yet to bring them to the full scale needed to really, really make the difference that we would like to make. But Home and Healthy for Good caught on faster than I would have even intended it to do when we were invited to present to the Commission to End Homelessness, and by the end of it, it was endorsed as a best practice, which I thought was a little hasty, but again, people moved with this, and it became the model when they broke out later into the ICHH, our own state interagency council on housing and homelessness. They were promoting this is what the model that should be being adopted throughout. What's really unique about this is that it's one of the few pieces in the budget that actually mandates cost evaluation. And again, I would love to think that we are being guided today by morality and the like at various state houses around the country. But the truth is the moral argument was not persuading people. What was persuading people was efficiencies and cost, that you could do something different. With CSPEC, for example, one of the conditions under 1115, it needs to be budget neutral. We have increased that every single year without increasing the state budget. And probably that's because it saves Medicaid so much. But again, what happened was, this is the political advocacy side of the story, is it started to build some momentum. The Housing First program, CSPEC, Home and Healthy for Good, and of course everything that was at the same time happening around the country, and the unique savings pre-housing to post-housing for people really caught people's imagination. The Public Health Commission had convened groups together as well to start focusing in on who are the highest users of emergency resources around the city. And then again, through some of the advocacy, and Home and Healthy for Good and CSPEC helped incredibly. One of the great stories was the president of the Boston City Council, Michael Ross, picked up on this tremendously, and he had heard an anecdote about people in the emergency rooms, and so he held hearings that he invited state Medicaid to, the state DHCD, which oversees our shelters and housing, and it just kept building momentum. Finally, Boston Healthcare for the Homeless, again, working with Boston Medical Center, got the players around the table, and they started to create a working group about how to address this within the context of the hospital system. And the end result of that is what I like to call Home and Healthy for Good on speed, in some regards, is Hughes to Home, which Jim will probably give you more details on, but this is specifically targeting the so-called high utilizers. And it's really targeting people. Jim is probably known for anywhere from 15 to 20 years, but these are people within the Boston Medical Center where it started. And I will leave this, the rest of this for Jim to share in terms of the dynamics of this. But there's some interesting stuff that started to happen. I had put together some slides, and I know I have some limited time, but this can be available on our website for you as well. But again, it just highlights the populations that we were serving. Now, this is Home and Healthy for Good data. One of my hopes is that we're slowly but surely getting to the point where we're going to be able to integrate all of these programs and have some solid data in terms of what happens. Here's the most significant thing in Massachusetts, and what made CSPEC most important is if you can see in terms of the people who participated in Home and Healthy for Good, that Mass Health, they are all insured through Medicaid. And again, we were able to build momentum in 2004, 2005, because Massachusetts was struggling at that point in terms of trying to create universal health insurance, and that made our argument at the time that homelessness was a public health problem, was a medical problem, very strong. And given the fact that so many of the chronic homeless are actually insured through Mass Health, don't they have some responsibility as well in terms of the solution? This is just, again, reflects the level of disability. This is all presenting information through the Home and Healthy for Good study. The active substance use one, for example, I think is low. But again, all of them had some significant disabling condition. And again, it was a focus around the state in various programs, and I contend it varies from community to community, but all of it was focused on the longest, the people that they'd known the longest, who they felt were least capable of housing. Those were the ones who should be targeted. On average, people had about, on average, 4.5 to 5 years of homelessness. So I'm being told I have to kind of wrap this up at this point. You'll notice about 30% came right from the street, but let me just show you what really sold it in Massachusetts. That's the annual savings per person based solely on the self-presenting information. That's our data. But as you will note, that the pre-housing costs exceeded significantly the post-housing costs, including the housing first costs, and including, again, some of those other health care costs that we're referring to. But finally, this is the one, this was Medicaid's own data for the first cohort to go through Home and Healthy for Good. That was their data, not ours. That was their analysis. Presently, that's at the Kennedy School, the entire set of data. You could invite me back to talk to you about social impact bonding and what's happening in Massachusetts. Maybe we'll be able to talk about that later. But that's what made the difference. Now Jim's going to tell you how difficult it is to do, I think.